Good morning, everyone, and welcome to Chart and Shield Primary Care Edition. My name is Gerardo. I'm a family physician, founder and CEO of Chartnote. At Chartnote, our mission is simple: help clinicians work smarter, not longer, so you can get through your charts and still have a life outside the clinic. If you ever wrap up a morning clinic already behind notes, or found yourself finishing your charts late at night with cold coffee and an open EMR, this session is for you. I'm thrilled to be joined by two remarkable guests today from Canada, Dr. Pewarchuk and Dr. Jasdeep Saluja, co-founders of Aroga Lifestyle Medicine. Jesse is Aroga's medical director and internist and geriatrician, double board certified in obesity and lifestyle medicine, and passionate about systems innovation and treating root causes of disease. Jasdeep is Aroga's Chief Medical Officer, also board certified in lifestyle and obesity medicine, and guided by the belief that your health outcomes are predictable if you have the right tools and guidance. Together, they built a practice that blends medicine, coaching, and technology, and they found ways to make charting faster and efficient. Towards the end, we'll have a short Q&A session, but please feel free to drop your questions in the chat along the way so we can make this as interactive as possible. So grab your coffee, get comfortable, and let's dive into how we can all chart smarter, care better, and maybe finish on time for once. So Jazz and Jesse, thank you so much for being here today. Let's start with your story because it's really interesting how you guys came up with Aurora. So you both came from internal medicine backgrounds. What motivated you to co-found Aroga Lifestyle Medicine and step away from the traditional hospital model?
Go ahead, Jess.
Thank you for the warm welcome, Gerardo, and welcome everybody. It's a great question. I was your traditionally trained internal medicine doctor in Canada. My journey into what led to create the co-founding of Aroga with Dr. Pewarchuk as well as Amr Megan started with actually just personal health issues in our family, right? In 2012, my father had a stroke, and in Toronto, while he was in Toronto, got taken care of. Everything came out of that acute health issue very nicely. And he was put on all the appropriate medications, had the appropriate surgery. Nobody talked to him about it, making any changes in his lifestyle or anything like that, any preventative measures. And then in 2015, we were taken to the hospital for his heart attack. Again, he had great care at the hospital, had his angiogram, got his stenting done. And really the only thing that was changed on medication list was, the addition of one more antiplatelet therapy, right? And after that, it was like, okay, wait a minute. Like, again, could any of this have been prevented? Could we have done anything? And that's when we started looking into dietary and lifestyle changes, especially because my family has a strong cardiac, history. And I was in my early 30s thinking, is this going to be my destiny as well? Like, am I a slave to my genes? And that's when I found the work of Dr. Esselstyn, Dr. Dean Ornish, other luminaries in the field of lifestyle medicine. And we just started making these, changes and learning how to eat differently and learning, about increasing our physical activity, the importance of sleep, stress management, start working within our own family. And then in the time that I'd started working on this, I got actually hired out to Victoria by Jesse at the hospital. And when I transitioned from Toronto to Victoria, the new job, the hospital position that I had also included an outpatient element, an outpatient internal medicine clinic through the hospital, where we would do stress testing and do cardiac risk stratification for patients that were referred from the emergency department or from the community. And while we would lay out the risk factors and find patients had slightly elevated A1Cs, slightly elevated LDL cholesterols, and started talking to them about, we would normally start to talk about metformin and pharmacotherapy. But because I'd been doing this lifestyle change thing at home, I started talking about it with my patients saying, hey, we could give you 3 months if you wanted to, if you felt comfortable working on a few targeted evidence-based changes, going from there. And found that a lot of the patients were actually excited to get the opportunity to potentially, maybe delay initiation of medication or even at least complement, the initiation of medicine, right? Because they can work hand in hand, right? And so started doing that about 6 months deep into that, and I was having a lot of fun with that. One day, me and Jesse went out for lunch, and then he started telling me about that this is what he's been doing, independent of knowing that I'm doing this with in the same clinic. He started telling me about how he's having all these great successes, patients putting their diabetes into remission through dietary and lifestyle changes. And I was like, wait a minute, but that's what I've been working on. And it was this moment where we both realized that independently we had our own journeys to the same realization that the status quo of just the way we do medicine is, here's your ill, here's your pill, and here's the bill, I guess, in the States, right? It's not really serving patients and communities in the way we all actually are truly hoping to do, right? And everybody's in it for the right reason. And so we realized that the missing part was building out an entire team to empower patients to, alongside pharmacotherapy, also work on lifestyle and dietary changes. And that's how the idea of Aroga came out, right? And Josh, you can take over from there.
And yeah, so this was around 2012?
This this conversation that we had was in 2017.
Yeah,
2017, sorry.
But the
2016, I guess, yeah.
2017, yeah.
And you started Aroga when?
2017.
2017. Well, Jesse, I wanted to ask you at the time were the chief of internal medicine at Victoria General Hospital.
Yeah,
right?
well, at the both of the hospitals, like our hospital system is kind of like one hospital with two campuses. I'd been chief for 4 years, and obviously doing all the things that is involved in running a significant sized set of hospitals on the internal medicine side. Not something I'd recommend to anybody. So I mentor people and say, you know what, that's probably a part of your career that you can just neglect and let be. But at any rate, it was during that time that it was actually my wife, who's a family doctor, who was trying to figure out why it was that despite running marathons, she wasn't able to really get as healthy as she wanted to get and couldn't lose weight and all of these things. And so during her second maternity, she dove into the literature, and I was coming home from work and she was giving me these spiels on the latest things that she found on PubMed. And that was how we found out about the work of Dean Ornish and Esselstyn and others. We started implementing that in our life. And I mean, holy crap, it was remarkable how quickly we became healthy. I mean, I lost 30 pounds and I went from having chronic inflammation in my ankles to the point where I couldn't even walk a golf course, to being able to run a half marathon. And I never thought I had a football injury when I was 17, and I never thought I'd be able to do something like run. And it was just all inflammation, and it was from what I was eating. And Nicole lost so much weight that because she was on the national swim team, the Canadian national swim team, when she was a teenager, and she's like, I'm the same size I was when I was on the national swim team. And this was just applying lifestyle medicine's principles. And, Nicole's like, well, you should do this with your patients. And so I started doing it with my patients, and it's like, it was incredible, watching people's A1Cs go from 11.7 to the low 6s without using drugs, just by using your words, and coaching people and telling them, how they could change their life for the better and their health for the better. And it is very much a red pill moment, like from the Matrix. Once you've seen that, you can't go back, right? And the problem is that we're not that different than America when it comes to the way our hospitals are run, right? It's sick care, right? And the hospitals aren't interested in running a program that, at its roots, is it's a time-intensive program that's for prevention, really, truly. It's secondary prevention, but prevention nonetheless. And so we, it was good fortune that Jazz had the same realization on the same timeline, and both of us were like, you know what, we're not going to be able to be our best from a career standpoint, actually do what resonates with us if we stay in the hospital. And so we took out a big loan, and we got a space, and we, my relatives thought that I'd gone insane. My uncle actually said as much. The people at the hospital thought that I had somehow gotten into a midlife crisis. And there are all sorts of things were being said, and I know they're like, what's happening to these guys, like, but the reality is that when you've seen something that is better, you can't look away from that. And if you do, that's a very cynical thing to do. Now, the problem is doing the type of medicine that we do, in order to be able to actually make money doing it, you have to be able to do it very efficiently, which means that you can't spend all sorts of time on charting and on information management and what have you. And so solving that problem became a very, very important piece of our business. And it has to this day remained a very important piece of our business. In the early days, long before Chartnote existed, long before OpenAI became closed AI. In fact, probably before the handshake between Sam Altman and Elon Musk, we were using a fairly clever system of generative questionnaires that would pre-populate our charts in order to minimize our time. But even that, I mean, it's clunky. Patients, some of them liked it, a lot of them didn't. It wasn't the best, right? And it still left us with a situation where if it wasn't something that was purely according to protocol, that we'd have to go and dictate or type, and these, as you know, are time-consuming things. So here we are, instead of spending the evening on call in the emergency room, we're spending the evening doing charting, right? Frankly, because I'm doing what I'm loving, I'm much more okay with that in 2018, 2019, but still, it's not ideal. And so that, fast forward to the pandemic and AI, and we start learning about scribing, and it, we're nerds at heart. I fortunately never needed the glasses, but every other piece of the archetype I think fits. And as soon as the concept of the generative chatbot comes along, right, we're like, oh, gee, there's some application here. And of course, we're clinical doctors. We're not going to build technology. We use technology. And so the two of us got into testing these technologies as they began emerging. And we were very fortunate that in our initial survey of things, one of the products that we encountered, of course, was Chartnote. And to say that this hasn't radically changed our lives for the better would be an understatement.
Well, Jesse, thank you so much for sharing that. But before we talk about the elephant in the room, the charting problem, I want to just dig in a little bit on your entrepreneurial journey. Because, I mean, to me, being an independent physician, it's very gratifying. So I wanted to ask you, you've been doing this for 10 years. Almost 10 years, right? So what surprised you the most about running your own clinic versus working for someone at the hospital, a big employer?
Jazz?
Oh, that medical school and residency does not prepare you for any of it.
No,
There's a lot of different hats that, or I say turbans that you have to wear, because we've grown to we've got a team of, over 35 doctors that work with us in different amounts of, capacity, administrative team, right? We have an amazing team, but a lot of that takes a lot of time, energy, and a lot of new skill set development that we don't know is necessarily have that through our training.
Well, I don't think you have it all through our training. It's it was a crash course essentially, and any doc that's left an HMO or a hospital and gone out on their own. I mean, it literally, you're forced to do a impromptu MBA, several of them, and get a passing grade essentially from life, or else you go broke, right? And it's stressful. It's a very different type of stress than being on call and having a crashing patient in the acute care unit, right? But it's very stressful. I mean, making payroll. I mean, like my friends that went into the trades at 19, they've been doing this for 20 years. It's second nature for them. For me, it was a big learning curve. And You know, in the early going, when we were just getting going, making sure we had the revenues to make payroll, a stressful thing, right? And, you know, sometimes you had to dip into your savings to make sure people got paid. And there's that. And then regulation, right? Like, you know, you read about people complaining about business regulation, you know, you hear about it, but you don't really realize just how bad it is until you're in there. And you realize how many stupid little rules the government makes you comply with simply to provide a service to people. You know, you learn this and you get good at it because after all, we're all doctors, right? We're very much type A personalities, and, you know, okay, great. We got a challenge. We're going to conquer that challenge. Right. And, you know, after a decade, you know, the most important skill actually is one that the two of us were good at already coming into this. And you don't really realize it's the most important skill until you're at a stage where you know what you're doing well enough that you can do it. But it's delegation, right? It's building a really good team, trusting the team, and then knowing how to delegate tasks and trusting them to get that done. And that is, from an entrepreneur standpoint, if you can't delegate, I think you'll go insane. You know, I really do. And I think that I really think that in the last 10 years, that's a skill that we've, both of us have actually honed quite well. And I think it's one of the reasons why the organization has grown so much and become, you know, I mean, in certain cities, it's with the right people, you might say it's a household name, but it's certainly in the space of obesity and metabolic medicine, extraordinarily good reputation.
Yeah. How many clinics do you have now?
We have 3 full-size clinics, and then we run virtual clinics to cover 2 provinces. So British Columbia and Ontario, which are the 2 largest English-speaking provinces in Canada. Yeah.
Well, congrats. Well, now moving on to the shorting problem. I mean, Canada is a bit different, being that it's universal healthcare and a single payer. How big of a problem is documentation burden in your world?
Well, currently not for me, not much of a problem.
It's the same sort of problem you guys have, right? Like,
it's the same. Yeah. Like
if you didn't write it, you didn't do it.
Yeah, exactly. Right. And so when you submit your bills it's like just like submitting it to any other insurance company, you're just submitting it to the government payer. And they have their criteria as like what constitutes a consultation, a follow-up, all of that, a complex consultation. You just got to make sure everything is appropriately documented, right? And they're like, when Jesse's saying people working in the evenings, I think anyone that's watching, anyone that knows this, like, it's common for doctors to take work home, right? An hour to 2 hours in evening charting, you hear about it all the time, right? Or if they're not taking it home, they're staying extra time at the clinic, right? They're finishing up there and they're getting home late, right? And their own lifestyle is being impacted because when you're getting home late, you're not going to go for your workout. Barely get time to spend with the family, get your quick dinner in. Maybe you're eating while you're at the desk, all of that, right? So the burden goes beyond the time that you're spending on it, but to also what other things are you actually missing out on, right?
So, I mean, you seem to use technology pretty intentionally. How did Chartnote change the way you practice?
So it was different. It was kind of in stages, right? Because when we first learned about Chartnote, at that point, it was like, we were introduced to it by one of our medical directors, actually our Ontario medical director, Dr. Amardeep Mangat, had started using Chartnote with the snippets. And so we started using the snippets. It was early days. And even those we found like, okay, these are already helping people go faster. Like even till this day, I still use a snippet, the snippets here and there, to quickly just get some information onto the page. So that was like already, we were like, okay, this is faster. As Jesse had mentioned, we were using questionnaires and templates. So we had templates and questionnaires. So we were probably already less burdened than other colleagues who weren't even doing that, right? Because that's the whole level of like efficiency. But we probably had a 10-20% efficiency at that point. Add some snippets in, and then for the actual AI scribe component, it completely blew it out of the water, right? Like I haven't taken an actual note in more than 2 years now, right? But the beautiful part about the scribing part is the efficiency is not just on the documentation that we need for the EMR, because that's just the system of record that we need for the payer and the regulators, right? But a lot of times we're talking to patients, and they're like, oh, can I get a summary of this? Can I I wish I knew this later, right? And the fact that with the AI scribe, especially with Chartnote, with the click of a button, it can do a summary in almost any language, right? For patients, and then I copy and paste that into a message straight from the EMR to the patient's inbox, right? And so they have that before they've hit the front door. It's already waiting for them in their inbox. That's a level of efficiency. But it's not just it's an efficiency in terms of getting the communication to who I actually care about the most. Beyond the regulars is actually the patient. Like the patient needs to know what we talked about so much more than actually the regulators need to know, actually, right? Because it actually affects their lives. And so being able to now do this and on an easy basis, previously it used to be like, okay, I've got a note, now how I'm going to type up a quick summary for this patient, I'll just do a couple of key points, it's time out of the day that, and it's not paid work, right? And, you add 2 minutes per patient, that you saw that day, you've already added like an hour and a half, extra work, right? And so oftentimes you wouldn't do it. Like how many times do patients get summaries from their doctors of today's visit, right? It doesn't happen. It's not because nobody wants to do it. It's just, how do you build it into your current schedule? With the AI scribe, it's just one extra little, one push of a button, right? At the end, or click on an icon, and that's done, right? So I think that's massively transformed things. And we actually ran a report because so we get, obviously we do consent for all of our AI scribing with our patients. And we just ran a report yesterday. Out of 7,600, I think it was like 75 had said no to it, right? So
Wow,
it was pretty much a 99% rate of saying yes, please use the AI scribe after reading a full page of informed consent.
The other thing so I mean, again, as part of an office practice, right, an independent office practice, we have to do volume, right? And on top of that, we're in a field where there is immense volume, right? Like, I mean, Canada is just half a step behind the United States in the obesity epidemic. A lot of people don't realize that, probably in America, but we are just a few percentage points below the US for all of the different classifications of obesity. Might be a different cause. It's not McDonald's up here. It's more Tim Hortons, but same basic idea. It's sugar and seed oils, right? So there's this limitless pit of referrals, right? And the only way you're going to get those referrals seen, aside from adding doctors, and by the way, we're recruiting. We've had 5 American doctors join us in the last 5 months. We have a whole system around bringing people up from the States, welcoming them, getting their licenses and all that stuff. So if you're an obesity doctor or an adjacent metabolic syndrome doctor, hey, come to Canada. But the only way you're gonna manage volume is to be able to see volume, right? And the other thing about seeing volume is it pays the bills, right? But the problem with seeing volume is it makes you feel freaking tired, right? And it gives you, as Jazz says, even 2 minutes per patient. Okay, so you did 25 consults, right? Well, that adds up real fast in terms of your evening work. So for me, every little place where I can shave off administrative work is either more time with my kids, or it's more during the workday, more ability to see more patients and try and draw down that wait list to something reasonable. So prior to Chartnote, my consultation times, depending on the type of consult, were between 30 and 60 minutes, right? Because you've got to do your standard internal medicine interview. You've got to do all of the different components of what constitutes a consultation. But then on top of that, you've got documented, right? And I'm a pretty fast typist, so I'll often typed it myself, but dictation was also something, and we did have templates for the more routine things like type 2 diabetes. Enter Chartnote though, and in the early going, we all know that ChatGPT-3 was not as powerful as ChatGPT-5, right? It made more errors, it confabulated more, etc. And we watched as these new large language models updated, and as you guys applied them to Chartnote, that the model got more and more and more accurate. There's a whole lot less in the way of editing that's necessary. And quite frankly, now the model is producing more accurate notes than my senior residents produce. To me, that's the real litmus test, right? If it's not that it doesn't make mistakes. I mean, it's a large language model. It's not perfect. It's no more or less perfect than an expert human, right? But if it can perform at the level of a senior resident, I mean, man, that's incredible stuff, right? Because that's what I'm looking for, right? So what happens is all of a sudden I'm just proofreading, and I can proofread at light speed, right? Make a couple of small edits here or there. And I've faxed my consultation off to the referring doctor as the patient's getting into their vehicle in the parking lot. You can't overstate how powerful that is as a consultant in terms of driving further referrals, right? And then on top of that, as Jazz says, you've sent off your summary to the patients, so they get home and it's already in their inbox, right? And for me, because I'm able to do all of that in such a short period of time, rather than trolling people on discussion boards like our national newspaper, I'd rather see more patients, right? And so now my consultation time is 15 minutes and 30 minutes. I've effectively doubled the number of patients I can see per day. And the crazy thing is that I am totally finished at 5 p.m., which is when I finish my clinic day. I'm done. I am done. I press a button to fax the last consultation. I close my laptop and I walk off to the parking lot and I go home. And that's such a departure from how things were 5 years ago. And it's an incredible thing. And I don't think people really understand just how powerful that is. And the really crazy thing is the multiplier effect it has on your income, right? People don't believe it. One of the big hesitancy people have of leaving an HMO or leaving a hospital is, oh, am I going to make enough money? How am I going to be able to do what I'm doing in the hospital? And there's no overhead in the hospital, blah, 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 right? Like we're making 50% more than we were making when we worked in the hospital. And it's because of these types of efficiencies, right? They make a gigantic difference. And at the same time, you see the volume, but at the same time, you're able to love what you're doing. And the patient loves it because they feel like they're getting full attention. You're making eye contact with them rather than looking at a screen. It's really great.
Yeah, so I wanted to talk about that. I mean, the time that you can spend with the patient. So just tell me if I'm saying the 6 pillars of lifestyle medicine correctly. It's like exercise, diet, social interactions, sleep, avoiding drugs, and which one am I missing?
Stress management.
Stress.
Yeah,
Okay.
so avoidance of risky substances and stress management. Yeah.
So, I mean, as primary care physicians, I mean, we know about this, but we have a packed schedule. We have a panel of 2,500 patients on average.
Yeah.
And usually we don't have time to discuss this, right? So how do you, in general, like a practice of lifestyle medicine, how do you make time for this kind of visits that, initially we were 30 in 1 hour.
Yeah.
And what's, I mean, at least in our system, one, there is no time, and second, there is no financial incentive. So how does it work over there in Canada, and maybe how could it work here in the US?
Yeah.
To focus more on those root causes of the disease, right?
For sure. So the way we set things up, so our consultations, for example, someone's referred to us for obesity management or lifestyle management for a chronic metabolic disease. The patients at this point in time still get questionnaires sent out to them anyways, right? Even though we're using scribes and all that, they still get that out. They fill out those initial questionnaires as well. Some of them do, some of them don't. Prior to our visit, we actually have intake coordinators who will do an appointment with the patient and get more details, flesh out the details. In fact, our intake coordinators are now using Chartnote as well, right? So we've already built that into we've started to pilot it with them, and then we're trying to work on actually building a new workflow with them as well, where the Chartnote note stays in Chartnote and continues with us, right? So that's another project that we're just working on. But they'll initially see the patient. So we have a lot of information up front with the patient already. the intake coordinator has already done a brief introduction as to how our consultation is going to go. And so we've got their blood, because they've done all their blood work before they got in here. They've got their ECGs, their vitals are already taken care of by our team to the doc. And so you've got a lot of the information. It's really just connecting with the patient, saying, hey, what are your goals? Why are you here? Why do you have these goals? How can we work together, right? And do you want, for example, if I use obesity as a case scenario, it's like, we can work on pharmacotherapy. We can also work with you on dietary and lifestyle changes. That's another umbrella. We can do both of them together. We can always, set you up for bariatric procedure, because we're also connected to the Island Health bariatric program. So we got to tell them, here's the whole menu of things that we can go into. What speaks to you in this moment in time? How do you want to, proceed? And people's journeys change, right? Some people, I've had patients come in and say, hey man, like, I've been hearing about this GLP-1 receptor agonist. Tell me about this. I'll go right to it, because my approach to treating weight management is to really honor the patient and patient first, right? And so we'll get to that. But even in the conversation about the GLP-1s, we'll go as we get to the side effects and going to efficacy. It ends up being a lifestyle medicine conversation anyways, because true informed consent really is, you got to talk about the alternatives, you got to talk about how to manage side effects, and the true management of side effects, and optimizing efficacy of these medications is healthy eating pattern that's going to be associated with it. Also getting you on a resistance training regimen that's going to support preserving muscle mass and all of that, right? So we get all that's done, and then from a team-based care, we use a lot of team-based care. So we've got clinical counselors on our team. So if a patient is coming in and we're seeing that they've got trauma, they've got other issues that from a mental health and emotional wellness perspective, we will refer to our clinical counsel and get them involved in the team. We'll also have dietitians. Our dietitians, alongside of our physician colleagues, actually run group medical visits now. And so we'll refer people into our healthy eating and lifestyle series. So they'll see their initial consultation with one of the specialists, in lifestyle specialists. They'll be referred into group medical visits. And I think group medical visits are like GMVs are paid, or I think they're called shared medical appointments in the States in some systems. And so we've got remuneration through the government for that. And that's a great way to provide care for patients as you're doing lifestyle medicine, because patients, they can be doing virtual groups of like 8 to 12 patients. You've got a curriculum, you've got pre-readings, you've got, facilitate discussion. We've got one on insulin resistance treatment program that we run. It's like 8-week program there. And patients really they enjoy the question and answer back and forth. They have ideas. Community gets built. So positive social connections is actually just taking place as a part of the treatment plan, which is pretty exciting. So that's how we do. So we do initial consultation. We'll do the group medical visits, and those group medical visits then allow for quick follow-up visits, periodic follow-up visits that just checking in, repeating people's blood work, their metabolic panel, saying, here's the things were like 3 months ago, here's where you are now. And then saying, okay, maybe we'll see you again in an individual basis in 6 to 7 months for consultation, but primarily working through a lot of our group medical visits, and then working with, some of them will work individually with our other clinical partners, like our exercise physiologist. He's running a group. He does group medical visit with patients, but he's also doing one-on-one work with patients as well.
So, it really looks like it's a team sport.
Lifestyle medicine is all about team.
Yeah, well,
and I think true comprehensive obesity medicine is the same thing. It's teamwork.
So we got a question from the audience, and they were asking that if you evaluated other AI scribe solutions, and why did you choose Chartnote?
Yeah, we looked at Jas, three other ones, and we actually use them concurrently.
I think I've looked at like more than it's probably half a dozen.
6.
I looked at a lot of them, and I don't really have anything negative to say about any of them. I think some of the initial days, some of them, they had one where they would do the scribe, but then they also would wait for a human to kind of look at things, and that slowed things down. I wasn't, I didn't think it was a quick turnaround time, so it wasn't really saving me time. For us, Chartnote made a lot of sense because the ease. I think one thing that Chartnote did really quickly, I found compared to the other ones earlier on. I think a lot of them were initially really focused on getting integrated with EMRs, whereas, and that was that was the early program but for me, it wasn't as much about, getting integrated in the ER as it was important for me to have proper templates, right? And so with the thing that I loved about Chartnote is the Chartnote wizard, the template wizard, right? Like we could go into template wizard and you can basically in a paragraph tell the wizard what your needs are, right? Like I'm a obesity medicine consultant. I need this structured consult letter. Each section has to have this, like as much detail, and it would literally build out the entire template. And so reason why I chose Chartnote was that actually it was creating the letter and creating the note that I actually really wanted and needed, right? And I didn't have to do I had to do minimal amounts of change to it. That's why, for me, Chartnote made sense.
Yeah, all of those things, and I would emphasize speed. Because unlike a lot of the other solutions, we would have a proper note that met expectations in terms of structure within 60 seconds of completing the actual visit. So while you're walking a person out to the waiting room, or after you hang up the phone, it's a very minimal lag between when you actually finish and when you're able to review the note. And I'm not somebody who likes to review my notes at the end of the day and then get them all done in one batch. I actually hate doing that because you forget, especially with big volume, right? Like, you're looking at as a consultant, 20, 25 a day, you're going to mistake in things. So I like to have it all done at once. And Chartnote very early on was able to meet that need much better than the others. And I would actually run two at the same time, and I would just compare them head to head. Like what do the results look like? How fast are they getting this done? And it was almost like for me, it was almost like what do you guys call it in the States? March Madness. We have the brackets, right? And it's just at the end of the day, Chartnote did it fast and did it accurately. And that was the decision point for us.
Yeah.
One of members of the audience was asking, how do you transfer the note from Chartnote into your EHR? Are you copy pasting or? I know the answer, of course.
That's a great question. Hey, did you plant that one there, Ardo? So we used to do that. We used to copy and paste. And there's a tool, you just press the copy button. You don't have to highlight, do all that. But Chartnote, that your guys is kind of, or at least what you told me at the start of the year, one of your big projects was to get as many of these integrations set up as possible. And the way you guys have done your integration is great, because you're not going to get API access probably to most EMR systems, but this very clever approach of having a Chrome extension that maps your Chartnote note to the appropriate sections in HTML opened EMR. It's an elegant solution. It works really well. And the nice thing about it, because again, I'm thinking about, okay, well, each click is going to cost me this amount of time, right? And each click is going to have an error rate on my part of clicking the wrong spot or what have you. Well, this once you've got that mapping set up for each type of consultation or follow-up note, it's one click and it goes done, right? And you can either edit your note if you need to in Chartnote, or you can edit in your own EMR. Either way, it's saving you clicks, it's saving you that annoyance of the copy and paste. But that's how it practically is working for us right now.
Yeah. So we did that very intentional. One, because we didn't have the resources back then to tackle the big EHRs, which at least here in the US is Epic and Cerner. Over there in Canada, is it TELUS?
TELUS and Well Health.
And they're both web-based, right?
Yes, that's right. All of the EMRs in Canada are web-based.
So for us, made a lot of sense to do the Chrome extension. We use robotic process automation, which is a fancy way of saying that we instruct the extension where to click and where to insert the text. And like you said, we don't need permission from the EHR because we're just reading the screen. And so it has worked pretty well for us. And our goal for the foreseeable year and probably next year is to continue adding more web-based EHRs, and then after that, it start tackling API integrations when it makes sense. Now, we're getting towards the end of our webinar, and I wanted to ask, what do you envision that the AI is going to allow? I mean, we're already seeing how AI is changing healthcare. And Jesse, you were involved. I think you were one of the first doctors that created a company about telemedicine in Canada.
It was Canada's version of Teledocs. Our capital environment is not as robust as yours is, so it didn't grow as quickly, but it still did pretty well.
So now the pandemic is over, and now we have AI. I mean, how do you see the merge of telemedicine with AI, and how do you see AI is going to impact healthcare in your practice in the next couple of years?
Well, I think that something that's universal: Canada, United States, Europe. Is a doctor shortage, right? Like there is a doctor shortage everywhere, right? And so one of the things that I think is going to be very interesting is, like, we use. I was having this debate actually at a doctors forum earlier this week with a couple of other doctors. We use the term virtual medicine, right? And really what we should be using to describe modern telemedicine, or telemedicine up to this point, is remote medicine, because you've got a human physician who is remote to the patient, and there's nothing virtual about it, right? We're all carbon units that are involved in the process, right? I think what's coming and what needs to come is actually true virtual medicine, and it's going to fill the gap in a lot of these rural and remote places, right? And as well as places where there's just not enough doctors. Right now, Canada's got a severe doctor shortage, and there's no way they can train enough to fill that gap fast enough as the baby boomers retire. So what does that look like? I think it looks like what I like to call pre-charting, right? And we've talked about this fairly extensively, and I know it's something that you guys have in your roadmap. But the idea that the system itself is able to have a conversational interaction with the patient in advance of the doctor's telemedicine visit, in a way that's not like dealing with AT&T help desk. It's actually conversational, and we're there. I think we're, in terms of compute power, right? So that patient can actually get a proper history done, and that the system functionally can be a bit like having a senior resident that is taking that history, getting everything organized, and then when you come in there as a physician virtually, you've got all the information you need. You're just like you do with an R5 or an R4 resident. You're just basically making sure that testing a few places to make sure they're telling the truth, and then going ahead and seeing the patient for what amounts to a fraction of the time it would otherwise take. Telemedicine is the first place you're going to see that type of prehistory applied, and the reason that it's going to be that way is because there's nothing that the machine can't do that you must do aside from assess the final plan, right? And so in the situation where we've got this doctor shortage, like here in British Columbia, I mean, our wait list is 1,000 patients deep, right? That's going to be a force multiplier on the existing doctors. That's going to, I mean, we've already been, as I've detailed to you, we've been 2x'd in terms of our productivity. I think that you're going to further 2x, maybe 3 or 4x. to the point where you might be able to have doctors legitimately do high volume telemedicine and do it well, in sub 10-minute visits, right? And that's going to be something that's attractive to everybody, as long as it's not a burden to the doctors. And so I think that prehistory, AI-driven prehistory, is the next most obvious step on the road to Star Trek Voyager's The Doctor. And I know we all fear that, but at the end of the day, The Doctor and the AI companies, the tech companies, don't want to assume medical liability. So I think being scared of that is silly. We still are going to have to sign off. We still are going to have to review. It's just like having a CTU, a team of trainees. Yeah, they're doing the work, but you're assuming the liability, right? And so being able to have a program that you can trust, right? Just like having a resident that you can trust, is going to be really critical. And it's going to be a force multiplier for those of us brave enough to be the first at bat.
Yeah, I think we share the same vision. I mean, our roadmap right now is to onboard more clinics and healthcare systems so that we can apply this agent. And we foresee this agent doing the patient intake and also doing follow-up. So they do the intake, then you review the information, you formulate the plan, and then a week later, this agent is gonna call the patient and say, how's your weight and how's your diet? And then it's gonna allow you to be more asynchronous and, like you
check
said,
for side effects, right? Like
even beyond like the agent making the call, there's be a companion agent where the patient can interact with them on their time, right?
Yeah.
Like, when they have because the amount of times patients, when you ask them, hey, any questions about the plan, and it's like, no, not right now, and then they walk out the door, and it happens to all of us. Like when I'm with my accountant, right, and I'm like, I had a great meeting with the accountant. I walk out, I'm like, oh shoot, I should have asked this, right? And so those oh shoot moments, they can just ask, they'll get to a point where they can ask an AI companion that's connected to your provider. I forgot to ask these questions. What do you think? And you answer, right? And so
well, it's super exciting, the future that we're heading to. And I wanted to thank you for your partnership and your time and with this webinar, and just wanted to close with if you could share some advice for some of our physicians, especially the younger ones. What would you tell them to help them avoid burnout and build a sustainable career in medicine?
Well, it's so for first principles, it's make sure you work with people that you really enjoy working with. Like the team that you choose to work with is a big deal. They're going to be around you for a long time. So I think that's very important. Do the work that you love doing and remember why you got into medical school, and then embrace technology that is, not so much, there's saving time, there's efficiencies, which is great, but remember that all these technologies have a huge potential to actually increase our human connection with each other as well, and keep the human part of medicine going, which is why I love this whole AI, this field that we're getting into. These technologies, actually, it's allowing you to be more human and less of the technician. Right?
Yeah, I think in addition to all of that, and I agree with all of what you've said, I think that it's also very, very important that a person, so doctors, especially when you're coming out of residency, you say yes to everything, right? And that's a one-way ticket to burnout, right? Because what you don't realize is that the people that are asking you, especially if they're administrators, especially if you're at a hospital and your senior administrators are asking you to do things, well, they're going to keep asking you to do things if you keep saying yes until you break, because they have a set of problems that need to be solved. And if you're going to solve the problems, great, especially since you don't need a raise to do that. Hey, here, go do that. Oh, hey, he's always he's always ready to play ball on this or that. The problem is that eventually you put yourself in a position where you're overcommitted, and when you're overcommitted, you end up again, because we're type A personality doctors, everybody's like this in the profession. What you start cutting the things outside of your professional life. And that, I've seen it over and over again with colleagues. That leads to divorce. That leads to really awful family situations. That leads to failure in life outside. Failure in life outside it's a catastrophe when it comes to your overall, quality of life. And so you have to protect that time, right? You have to learn how to say no to hospital administrators. You have to learn how to say no to senior leadership, but do so in a way that's not going to necessarily limit your career. So that's one thing. And then and making sure that, if your day ends at 5:00 and you're not on call, well, damn it, your day ends at 5:00, and make sure that you set your life up so that you can go home, right? Because otherwise, you're going to arrive home one day at 7:30 and you're going to find another man in bed with your wife, right? Like that's what's going to happen. And
worst of all, you don't get paid for overtime.
No. So I think that efficiency matters a lot. And the other thing that I advise the younger doctors, in addition to everything Jas said and what I've said so far, is always make sure that you carve out vacation time. And I've seen some young doctors go, oh yeah, no, I'll do more call. I'm going to work when my vacation is to make more money. It's like, no, man, the money's there waiting for you. If you don't take that vacation time, you're going to have a heart attack when you're 42 and you're going to be wondering where the hell you went wrong. Well, that's where you went wrong.
And just to end off with another way of preventing burnout is moving to Canada, signing up to work with the team that values. Here's a founder who's telling colleagues take vacation. Like, listen, if that's not a pitch, I don't know what is, right?
So where can they reach out if someone wants to work at Aroga?
I'm happy to give our emails. Like, there's Jesse.
Yeah.
Like, so Jesse,
email us founders directly. We love talking to other physicians that are interested.
Yeah.
Jasdeep, I think is your full name, Jasdeep at Aroga, AROGA.com, and mine is Jesse, like Jesse James. I think that'd be a famous American. So JESSE at Aroga.com, and that'll get you right through to one of the founders. And we still own and run the business, and so we can answer almost any question that you might have. And it has become very easy to come to Canada. The regulators have essentially fully recognized equivalency with American training now. So it's a very doable thing. So anyhow, we love making that pitch because we love our, there's a lot of political stuff going on, but we love them. We love our American brothers, and we very much respect you guys. And we'd love to have a few of you join us.
Yeah, well, I'm wondering when are we going to open Aroga here in the U.S.?
Aroga, California. Yeah. It's funny. Kaiser Permanente and us do a lot of, like, the vision's a little bit similar, right? And so, it's interesting though. There's some people in Los Angeles that are doing stuff similar to us that we know quite well, and these ideas do come up from time to time. But it's like we've got at least 2 more provinces that we want to do up before we start looking south of the border.
Yeah. Well, that's a great way to close. Jesse and Jasdeep, thank you so much for being here and for sharing your insight and your wisdom. And thanks everyone who joined us at the Chart and Shield Primary Care Edition. So if today's chat resonated, check out chartnote.com to learn more about AI-powered tools that make documentation faster. And until next time, happy charting and hopefully more chilling. And see you next time. Take care.
Thank you. Take care.
See ya.
Are you tired of eating lunch at your desk, staying after hours in the clinic, or working from home to complete your progress notes? Documentation is the main cause of physician burnout. Discover a simple fix to take back control of your time and enjoy practicing medicine again. Simplify medical documentation and have a meaningful interaction with your patients. Get home early from work and focus on what really matters. Chartnote AI Scribe turns your speech into structured notes in seconds. Fast, accurate, multilingual, and seamlessly integrated with your EHR. AI scribe listens, understands, and writes your notes in real time. Chartnote has everything you need to expedite your medical documentation. Chartnote, revolutionizing medical documentation with AI.